Welcome to the Congressional Hispanic Caucus Institute's 2020 Health Summit. I'm Congressman Ruben Gallego and Chair of CHCI. Thank you for joining us for the next 2 days of important discussions on emerging health issues, developments, along with the challenges they represent, and the opportunities to maintain and improve future health and well-being of the Latino community and our nation. For over 40 years, CHCI has forged a critical pathway to developing the next generation of Latino leaders, creating a transformative and lasting impact to young Latinos and our nation. Each year, CHCI educates, empowers, and connects students and young professionals by creating opportunities for them to have impact, offering unique access to influential leaders, and connecting leading employers with Latino talent. It is in this virtual space we will hear, learn from, and connect with some of the nation's most important and influential leaders in the healthcare field from the private, public, and nonprofit sector. We'll talk about the health and healthcare challenges, needs, and opportunities for the 60 million plus Latinos in the U.S. This year has presented us with a very unprecedented challenges due to the global pandemic. COVID has shed light on health disparities and inequities in communities of color, especially the Latino community that has been hit the hardest. The healthcare field continues to be a constantly changing environment with new and different challenges. For the next 2 days, together with my congressional colleagues, health policy experts, healthcare providers, medical professionals, advocates, corporate executives, and other stakeholders from across the country, we will discuss solutions to implement and provide access to programs, enable efficient operations and services for care and delivery, and support healthcare innovation and technological advancements. We are grateful to all the corporate partners whose support has helped make this summit possible. And thank you for being here with us today and tomorrow. Follow us at CHCI on Twitter, Facebook, LinkedIn, and Instagram, and use hashtag CHCI Summit. And now, enjoy the CHCI Health Summit.
The Health Summit wouldn't be possible without our partners. CHCI would like to give a special thanks to our host sponsors, Blue Cross Blue Shield Association, Genentech, and Novo Nordisk.
Hello, I am Marco Davis, President and CEO of the Congressional Hispanic Caucus Institute. Thank you for joining us today, and welcome to our opening plenary, which will address the topic, racial justice, the state of Latino health, and what lies ahead. Some have said we're living in two pandemics, COVID-19 and systemic racism. Since earlier this year, our nation has been reeling from the grips of this global pandemic. But the long-standing systemic racism and discrimination have exacerbated the negative effects of the coronavirus, putting many Latinos at increased risk of getting COVID-19 or suffering more severely from it. During this plenary, our speakers will talk about both pandemics and their impact on Latino health, and more importantly, recommend what needs to happen to put us on a course to attain better, more positive health outcomes for our community. Before we get into the discussion, I want to extend my sincere thanks to our sponsors, the American Federation of Teachers, Amgen, Gilead Sciences, Merck, Bio, and United Health Group for their generous support of CHCI and this Health Summit. And to begin the session, I want to introduce CHCI Advisory Council member, Congressman Jesus Chuy Garcia, who will say a few words in a moment. After Congressman Garcia, we'll be joined by Dr. Oxiris Barbo, Adjunct Assistant Professor at Columbia University Mailman School of Public Health, who will serve as the plenary moderator. Thank you for your time and attention. Remember that you and your colleagues can follow the live stream of this session on Facebook at CHCIDC, and be sure to post on social media platforms with the hashtag CHCI Summit. We hope you enjoy the discussion. And now, Congressman Chuy Garcia.
Welcome to the 2020 CHCI Health Summit. I'm Congressman Chuy Garcia, and it's my honor to join you in this conversation around racial justice and the state of Latino health in our nation. We just witnessed the most important election of our lives with so much at stake for the Latino community. While the next 4 years may look different, we also know that the fight against COVID-19, which has devastatingly impacted our community, is far from over. We are more than 8 months into the pandemic, and I know that each and every one of us has been personally impacted. Whether it's a loved one who has lost a job or died from COVID-19, this year has tested us more than we ever imagined. COVID-19 demonstrates not only that we have a deeply flawed healthcare system, but it also exposes the persistent health inequities in the communities of color. There are still language and cultural barriers that must be addressed. While the ACA expanded access to healthcare in historic ways, many Latinos and Latinas remain without access. Some immigrant families simply forgo healthcare altogether, especially under the Trump administration, because they're fearing interacting with public agencies. These are only a few examples of the barriers our community continues to face. The inequities we continue to witness are not naturally occurring, and the structural racism we see in our healthcare system did not happen by accident. The disproportionate death and suffering afflicting Latino and working class communities was in effect explicitly codified into law. Reversing this damage requires us to take bold steps and write the racism out of our laws. Anything less will perpetuate the inequities that are literally killing our communities. With that, I turn it over to the experts in the field who will shed light on the public health disparities before and during the pandemic, what lies ahead for our community. Thank you, everyone, for joining us, and thanks to CHCI for organizing this timely and important conversation.
Welcome to our opening plenary, Racial Justice, the State of Latino Health, and What Lies Ahead. I am excited to be joined by a dynamic group of leaders who I will introduce in just a moment. Today, the biggest threats to the health and longevity of Latinos are preventable diseases, which are crippling the community, including the financial burden of medical bills. The root causes of many of these preventable health threats are inextricably linked to the conditions that shape people's opportunity to attain good physical, mental, and economic health and adopt healthy behaviors. They also include longstanding systemic racism and discrimination that have put many Latinos at increased risk of getting COVID-19 or suffering from more severe effects from it. This session will start with a discussion on the current state of Latino health in the United States and what lies ahead, and will be followed by a discussion on effective strategies to address systemic racism, discrimination, and bias. Our experts will uncover the biggest and unique healthcare challenges facing U.S. Latino population today and outline solutions-based policies and practical approaches to increase health outcomes and mitigate discrimination, bias, and racism that have perpetuated generational cycles of poor health and risky health behaviors. Today, we will engage in a wide-ranging conversation, which is especially timely as our country continues to see daily record numbers of new coronavirus cases, hospitals in many parts of the country on the verge of being overwhelmed, and roughly 1,000 Americans dying every day because of COVID. As an overview, I'll ask questions of the panelists for about 45 minutes, and then we'll turn to questions from the audience, and we'll close with summary remarks from each of our panelists. For those of you on social media, I encourage you to use hashtag CHCI Summit. Let me start by introducing Dr. David Hayes Bautista, the director of the Center for the Study of Latino Health and Culture at the David Geffen School of Medicine, UCLA. Dr. Bautista.
Thank you. It's a pleasure to be here. Well, actually, why should anyone care about Latino health? Be they Latino, non-Latino, Republican, Democratic, Independent? Well, let me reframe the issue why everyone should be concerned about it, and it has to do with our recently released Latino Gross Domestic Product report. Now, it turns out the 60 million Latinos in the U.S. have created the world's 8th largest GDP, and it grows 50% faster than the non-Latino GDP. The problem is that the coronavirus attacks the very behaviors that help Latinos create the strong GDP. Latinos have had the highest rate of labor force participation of any group, but this participation puts them in contact, it exposes them to coronavirus because most Latino work is in the essential areas that put them out in public, in close proximity. So COVID also attacks the family, the very family strengths that Latinos have. Latinos tend to have more wage earners per household, more children per household, but the coronavirus loves crowded household. Latinos set up businesses, are very vigorous business uppers, but that puts, again, Latinos in coronavirus's path. Latinos are rarely extended health insurance. Latino wages have been suppressed. And of course, we have the on-standing, long-going Latino provider shortage. So, and add to this, the past 5 years of very nasty anti-Latino immigrant narrative, when in fact 70% of Latinos are U.S. citizens. The Latino GDP can power the U.S. GDP through the coronavirus, through the pandemic. We are the growth spot for the United States, but we need to invest in Latino GDP growth. We need to expand health insurance coverage. We need to increase wages. We need to ensure that families are protected and that Latino essential workers are protected. That's how I would like to reframe it. Thank you very
Thank you,
much.
sir. Now I would like to introduce Randy Weingarten. She is president of the 1.7 million member American Federation of Teachers. Welcome.
Thank you. And let me also say, Dr. Garbo, thank you for all of your service, and thank you for actually making sure that people understood that this was a real problem and a real disease and a real virus that had to be reckoned with. And I just want to honor that and honor what you have done. So thank you very much for all of that. So, the bottom line is we live, I just finished, or before the election, November 1st, a 30-day bus trip to get out the vote for the candidate we were supporting, which was Joe Biden and Kamala Harris. And what we saw around the country, we were in 15 states in 30 days, is you have a tale of two countries. And what we need to do first and foremost is that that there needs to be a national understanding that the virus is virulent, real, needs to be tackled in order for us long term to reopen our economy, get our schools back, and make sure that our kids and working families have the shot of the American dream. And what we've seen in this virus, and Latino populations have seen this worse, is that the virus has exacerbated inequality. And it exacerbates inequality in so many different ways, in terms of kids who do not have schools reopening, in terms of parents who are essential workers and do not have the protections that they need from OSHA or from the other resources from the federal government. There's and when you look at deaths, who has been disproportionately affected? Who is disproportionately affected because of the lack of health care? And then who is also disproportionately affected because of the fear of what has happened, given that the Trump administration has refused to have a long-term immigration process that is based upon, on how we have a real that is based much more on fear than anything else. So we are seeing lots of problems, and we need a national strategy that starts with science and resources that prop up businesses so that we can keep people employed regardless and while we're fighting the virus, and that we have the safeguards necessary so that parents and teachers trust that we can not only deal with the surge, but long-term deal with reopening school buildings in a safe way to ensure that we are on in-person instruction safely and not continuing to do remote.
Thank you. Now it's my pleasure to introduce Eduardo Setlin. He is the president of the Amgen Foundation.
Thank you so much, Dr. Barbeau. The Amgen Foundation is the philanthropic arm of Amgen, or a medical biotechnology firm with a simple but powerful mission to serve patients. Science is at the core of everything we do in the biotech industry. Progress is all around us. So incredibly proud of our peers developing a COVID vaccine that hopefully will change the narrative and have an enormously significant and positive impact in our nation, in our globe. Uh, there are some reasons to be optimist. Our understanding of biology is better than it's ever been. In other diseases, we're able, for example, in cancer, we now are able to harness the immune system to fight the disease and win. We're able to find genetic variances and design meds that work with specific populations, all driven by human talent in labs around the world. Of course, the reality shared by my colleagues here is absolutely daunting. 2.5 times mortality rate for Latinx versus whites, 3.8 times for African Americans. Saw a chart by a colleague that showed that in certain states earlier this year, in Kansas, for example, the mortality rate for African Americans was 7 times that of white, 6 times of whites in Missouri. Even before COVID, one's zip code impacts their health outcomes and life expectancy. I'll give you an example. The city of Baltimore, Roland Park feels like Japan. 84 years old is the life expectation. Downtown, 66 years old, just like Pakistan. 6 miles apart and continents apart. So my job at the Amgen Foundation is to bridge these two realities, the optimism, the possibilities, and the harsh reality we are living. And we do this by investing in today's youth, particularly underserved minorities. We believe that the right investments now are key for the next generation to live up to their potential and play a leading role in addressing the enormous challenges we have at hand. Really appreciate the opportunity to be part of today's conversation and thank the Congressional Hispanic Caucus Institute for having this timely discussion. Back to you, Dr. Barbeau.
Thank you. And now it's my pleasure to introduce Dr. Eduardo Sanchez. He is the Chief Medical Officer for Prevention for the American Heart Association.
Thank you so much, Dr. Barbeau. It is such a pleasure and honor to be a part of this meeting, part of this panel, and to represent the American Heart Association. Our mission statement, and I'm not a mission statement guy, but when you hear this, you'll say, wow, is to be a relentless force for a world of longer, healthier lives. And back in the early part of this year, 2020, which seems like it was about 20 years ago, we realized that we needed to be involved in the conversation around COVID-19. In the meantime, we've just published a presidential advisory, which is our way of communicating important issues, call to action, structural racism as a fundamental driver of health disparities. So the two elements that we have been tasked to discuss are part of where the year started and where it appears our year is ending. And there is no doubt that our paper was informed, I would say even catalyzed, not only by the disproportionately adverse impact that COVID-19 has had on Latinos and other people of color, but also the events that maybe the pinnacle of which was the killing of George Floyd. I would say a couple of things. One, science is so important. And we need now more than ever science to drive a public health system that can help us get control again of COVID-19. And we need a strong but protected clinical care system to take care of those individuals, too many Latinos and too many others, who are ending up in the hospital and needing care. That creates the foundation, the backdrop, if you will, to allow Latinos and Latinas and others to safely and confidently thrive, as Dr. Hayes Batista was talking about earlier. And I would add, in line with what Mr. Setlin was saying, is that we need to create those systems to then create the STEM workforce that begins looking more like the population that it is serving. And just to be really clear, a STEM workforce that has a much higher representation of Latinos, Hispanics in that workforce. Thank you again for the opportunity to be a part of this discussion today.
Great. Thank you, Dr. Sanchez. So let's dive into our discussion. And let me start off with the first question. The U.S. currently has more than 11.5 million total cases of COVID-19, and over 252,000 people have died because of this virus. Across the country, Latinos have been disproportionately affected because of the trifecta of risk factors, including higher likelihood of living in overcrowded housing and or living in multi-generational households, and the greater representation in the essential workforce, increasing risk exposure. So from each of your respective disciplines, what don't these numbers and risk factors tell us that is important to contextualize for the current state of the pandemic and for the post-COVID rebuild as it relates to Latinos? And let me start with Dr. with Dr. David Hayes Bautista, please.
Well, it's clear that Latino households are the strong point of GDP growth. Latino households have more wage earners per household than non-Hispanic, and we have more kids. We're like America, the young part in the 1950s. However, in today's environment, going out and dealing with clients, dealing with co-workers, with meat packers, etc., exposes Latinos more to the coronavirus. Thus, their case rates are higher. And then as these multiple wage earners come home, even though the children and the abuelos, the grandparents, can't be sheltering in place, they can then bring the coronavirus into the household. So this is how the very behaviors that help generate the strong GDP growth are being attacked by the coronavirus.
Thank you. Dr. Sanchez.
Sure. I would say from three perspectives, there's some things we may be missing. From a disease perspective, Latinos, just like everyone else, need ongoing care for a number of health issues that are going on in the midst of COVID-19. Hypertension, diabetes, high cholesterol, more advanced heart disease. And what we are seeing is that fear of COVID plus loss of job and loss of insurance is resulting in people delaying getting care. From a social determinants of health perspective, there are folks who have lost their insurance, people who don't have the disposable income as a result of tight situations to pay copays and deductibles, even if they have insurance. And then we've got a large number of Latinos who are undocumented and just fear getting out and being exposed in any way. And then in a different way, from a social determinants of health perspective, food insecurity is a very real thing. Just 3 days ago, there was our food bank in Dallas, Texas, was distributing food, and oh my gosh, the lines are there. It's sad. It's disheartening how many people are having to line up for food. Job insecurity, obviously an issue, and then COVID-19. Those three things are contributing to increased stress, increased depression, increased anxiety. So disease, social determinants of health, and from a mental health perspective, those are the underneath the bigger issue of COVID-19 that we've got to keep paying attention to.
Thank you. Thank you for that. I'll turn now to Ms. Weingarten.
So, I think I would say the same as the good doctors on the panel. The difference, I think one of the reasons that I'm on the panel is that part of what I think about all the time is how do we take, if we had a different policy, how do we actually make it a reality? So we need different policy so that's why I would start with on the disease issue. We actually need a national government that understands that COVID is real and that the ramifications economically and educationally and health-wise have been real. And that, but if we don't start with, the reason I feel like I keep on saying this, if we don't end up having a national policy that says we have to fight the disease and we have to have stimulative effects for people who are in a situation where they feel forced to go to work, but for, because they're going to lose the roof over their head, they're going to not have food. We need small businesses to get that stimulus. We actually need individuals to have extensive unemployment. We need, a resurgence of what Andrew Yang's idea was of the individual stimulative checks. We need to create some economic security right now for people in order to then fight the virus. And then, separate and apart from that, we need to think about, and what the doctors were saying before, that we have to actually then figure out how to use schools and to actually address, stability, structure, educational acuity, and then we also have to deal with the issue of health insurance. And the problem is we have to do all of those things simultaneously. And what we've said before, and I'm so glad that CHCI is doing this, because you see a disproportionate impact on Latino communities and on indigenous communities and on African American communities. And so you see that urgency in so many different ways. So that's why I start with, in this new administration, national policy to fight the virus and mask mandate, finding ways to make science God, like CDC used to be God. How do we bring faith communities in so that from pulpits we're having the same kind of conversation? Where are the trusted messengers so we're having the same conversation? And at the same time, as we're trying to create trust in the public health aspects of this, how do we guard against and cushion against the economic aspects?
Terrific. Thank you for that. And now, Mr. Setling, please.
I think all I would add is the structural inequities in our countries are very much at the surface of the reality now. Poverty, wealth gap for Latinos, lack of upward mobility, very significant issues. And I think back to this understanding of the day-to-day life for the Latinos and Latinas in our country, we are 16% of the population, but we are 6% of doctors, 5% of scientists and engineers, 3% of law firm partners, 2% of Fortune 500 executives. Dr. Sanchez just talked about this alignment. Why aren't we represented to the tune of how many we are in the country? And I'll put it in the words of Lin-Manuel Miranda. As an immigrant, I've learned a lot about American history, and I'm a continued student in Hamilton. I was very helpful. He says, when he talks about the room where it happens, we are not there. We need to be in the room where it happens. We need to address the barriers that our youth faces in their paths forward towards high quality jobs, high quality careers, for two reasons. It's because it's a social justice issue, and because we desperately need their diverse talents to help address these issues. Talent is universal, opportunities are not. It is time to level the playing field, to give every student the chance to live up to their potential. And the sciences are the way to do it. Much work ahead.
Thank you. Thank you all for that. And if I could just sort of summarize, what these numbers don't tell us is the degree to which the importance of adhering to science and having people know that this is a real threat, the degree to which the underlying social determinants of health, be it food insecurity, be it housing, contribute to these numbers, Similarly, the degree to which underlying conditions, underlying barriers to accessing care contribute to these numbers, and the degree to which lack of representation and lack of understanding of how those attributes that make us an economic engine also put us at risk for further threats. So thank you all for that, I think, whole complete panorama, if you will, of looking at the issue for us. The second question is, as we look at the totality of the response, there are three large buckets of activities as I see them. One is basic science, understanding the virus and the development of therapeutics, including vaccines. The second bucket being healthcare delivery and the clinical component of this response, including access to care, underlying burden of chronic illnesses, as well as mental health supports. And then third, the community aspect of this response that incorporates both the dissemination of prevention messages, housing and food supports, as well as schooling. So from each of your respective disciplines, talk to us about the work that you and your organizations are doing to address inequities in these areas. And let me start with Mr. Setlin, please.
Thank you, Dr. Barbeau. I'd put it that the common thread connecting these three buckets is a significant need to improve scientific literacy, which essentially aligns with the answers we just discussed in the previous question. I'd put it that thinking like a scientist is a critical skill in the 21st century. I do not mean memorizing formulas. I do not mean memorizing the periodic table. I mean being able to ask good questions, to look for answers, both for yourselves and for your community, to know if the answers that you found make sense, to know fact from fiction, to communicate learnings. At the MJ Foundation, we are working to help build a scientific literacy society. And our approach is to focus on a suite of programs that provide hands-on and virtual experiences for students. And the two tenets that drive our work are, it's got to be high quality, it's got to be free. So never it's been so important to provide an excellent distance learning education. And while it's absolutely true that the digital divide is a critical issue, there's also a significant risk in simply moving to the virtual space what students did in the classroom. I'll ask a couple of perhaps provocative questions. How do we take advantage of this crisis to invent a different future? Perhaps one where standardized testing is not on the driver's seat of our schooling experience? Perhaps one where instead of stifling curiosity, we're able to give the room for it to flourish? I'll tell you briefly about two efforts we've undertaken. One with Khan Academy, they have 80 million users around the world. We have financed their biology content platform. When we started supporting them, they had 300,000 users a month on biology. Now they have 3 million. And that's before the pandemic. Now they have millions more. More recently, we also announced how we're helping 5 different school districts partner with Khan Academy to bring the content in their classrooms in a way that provides administrators and teachers with a clear picture of how learning is happening in their classroom. We're so impressed with Khan Academy that together with Harvard, we've launched something called Lab Exchange. We say the best way to learn science is to do science. We launched in January with 5,000 users. Now we have 2.5 million people using the platform. And I'll double click on one theme before I close, which is the role of teachers. The teachers have and continue to play a key role in these solutions. They are co-creators of content. They're able to combine what works, what's been proven, with the cutting edge knowledge that our scientists are discovering on a daily basis. The platforms and the technology, we talk about ed tech, the foundational requirement here is for students to learn good pedagogy and concrete partnerships with teachers. I'm very proud to see the evidence that the different future is possible and that that future is already here. The challenge at hand is that future is not evenly distributed yet.
Thank you. I'm going to continue the educational theme more or less, and I'm going to turn to now Ms. Weingarten to talk to us about how her organization and her members are working in this area of addressing inequities.
So I'm going to build on what Dr. Barbeau, I'm going to build on what Dr. Setlin just said, because the, you know, we have both found different places and have invested in different places where where we are seeing emerging best practices. But the issue in terms of equity is going to be how we get there for all kids instead of just some kids. So I would say that there's 2 or 3 things that have been emerging practices from, let's say, from last March through June. I want to separate that out from September through December. Project-based learning and community schools and wraparound services. When you have, and what Khan Academy does, and I was honored to actually have like a couple of hour podcast with Sal Khan, and I think we were both surprised about how much synergy there was because of all the kind of BMIS about us working together. Remote education is going to have a place now and in the future. It's not a substitute for in-school learning, but we got to get the platforms better, and it's going to have a place, and frankly, it's going to have a longer-term place. But it's not a substitute for what we're doing for in-school learning. So what can we do? What does Khan Academy do? What does project-based learning do? It basically allows kids to hone in their skills of teamwork, not just resilience, relationship building, writing persuasively, problem solving from beginning to end. And those schools that actually had that kind of acuity, that didn't teach to the test, but actually taught this kind of methodological ways of doing, actually were able to finish the last school year better than most. And that crossed wealth lines, and that crossed racial and ethnic lines. The second piece that we've learned, so that then calls for what Dr. Setlin was saying. We need the platforms to be better. We need to figure out how we can actually figure out through hybrid learning how to do these things well. And we need to have literacy in science, in social studies, in math, in English, and we really need to figure out how we do this cross-pollination between in-school and some remote as this virus rages on. That's number one. Number two, what we've also learned, and this goes to something that Dr. Sanchez was saying earlier, is that if you actually have community schools, and you saw this, Dr. Barbeau, in New York City, the places that had wraparound service schools, where there was intersection with mental health services, with school-based clinics, with other kinds of services, you actually could meet the needs of families quickly. Think about that as an infrastructure for how we also create trusted emissaries for the vaccine. Think about that as an infrastructure for how we create trusted emissaries for, testing, like Somos is doing right now in New York City and other places. And so ultimately, if we can create the school as a trusted emissary, like, frankly, in Baltimore, they're doing at the Wolf Street Community School, and they're doing in different places throughout the country, you both bring services and trust together so that you can actually deal with a lot of the wellness issues. So I'm all for trying to figure out how we have 25,000 community schools in the United States over the course of the next year. How do we use the federal Title IV of ESSA to actually do that, have a coordinator in each of these places, and then use it as a way of dealing with the kind of services that families really, really need, including bringing other services in once we get the essential health services and mental health services, and then also thinking about instruction through projects as a way of actually getting through the rest of this year.
Terrific. Thank you very much. I'm going to turn now to Dr. Sanchez.
So you asked a question in order of basic science, healthcare delivery, and community. I'm going to go in reverse order. So I mentioned earlier that we put out a call to action to address structural racism in the United States, and would say to you that in addressing it, there's three really essential elements there. This is work that the American Heart Association is stepping up to do. One is to call out structural racism as a thing that needs to be identified and addressed. Do the things we can to dismantle structural racism. This paper includes a historical context that takes us to through slavery, emancipation, Jim Crow laws, the housing laws that existed that resulted in concentrated poverty and residential segregation that leads to the kinds of situations, Randy, that are about, and I'm more than happy to be called Eduardo, even though there's two of us. I'm a first name guy. So even though
I wanted to honor both of you.
No, I appreciate that. Your premises are and the solutions are really important, but in the long term, we've got to change this variability in tax base and the ability to support schools with dollars that results in such a difference. We're calling that out. And then also mitigating the effects of structural racism. On the healthcare side, I think I will just add to what's been being said. We've learned that remote platforms can work. Now what we need to do is figure out how the future that we want to create, borrowing again from something I think Eduardo said, how do we create the future that brings a hybrid healthcare delivery system that has the right mix of high touch and high tech, that is serving people. And the term I heard today, not a new one, user-based design. How do we talk to patients? How do we talk to caretakers and help them design these systems? Because too often it's smarty pants like me that think of something to do and really it just doesn't work for people. And then lastly, on basic science, I would say the American Heart Association very, very, very quickly put $2.5 million into the research funding arena to fund about 15 small studies looking at the basic science relationship between COVID-19 and cardiovascular disease. We did a couple of things very intentionally. One, we wanted to get some insight, but we also prioritized and looked to support scientific investigators who come from underrepresented race and ethnic groups. So trying to do two things at once: solve for the problem of figuring out some solutions and begin empowering scientific investigators who sometimes are not given opportunities through the normal channels that we fund things. So thank you for that question.
Thank you. And now I'll turn to Dr. David Hayes Bautista.
Thank you. Thank you. Well, actually, I want to put something across all three buckets, a problem I see in all three buckets, and that is there is a U.S. narrative about Latinos that doesn't see Latinos as part of America. And one of these issues we've mentioned here many times, which is the need for services in Spanish in medicine, messaging in Spanish. And I usually get pushback, people saying, hey, this is America. We don't speak Spanish. We speak English. Well, the fact of the matter is, in California, medical services have been provided every single day in Spanish for 251 years. And when California became part of the United States, the California Constitution of 1849 protected language rights, and California came in as a bilingual state. By the way, that same Constitution also continued Mexico's previous abolition of slavery. California came in as a free state because Latinos insisted no slavery in California. And of course, that upset the balance of the Missouri Compromise, did lead to the Civil War. The California Constitution allowed descendants of Indians and Africans to vote, whereas in other states they would have been property. And the California Constitution of 1849 protected the rights of married women to own property independently of their husband. That was actually a very revolutionary constitution back in 1849, and it's all part of American history. And in fact, because of the California Constitution, because of Latinos, that led to the Civil War. Latinos were way behind Lincoln in the American Civil War. They also supported Juarez against the French, who wanted to bring slavery into Mexico. And that led to the original celebrations of El Cinco de Mayo, which were Latinos' way of stating to the world, here's where we stand on the issues of the American Civil War. We oppose slavery, we support freedom. We oppose white supremacy, we support racial equality. We oppose elitist plantation governance, we support government of the people, by the people, and for the people. Now, this is the Latino narrative about Latinos. We need to have that into the public policy discourse. I see it as needed in basic science research. I need it as being necessary in healthcare delivery and in community. We need our own narrative that we have as being part of the United States and what is now the United States since 1511 in terms of providing service, when the first hospital was set up in Puerto Rico. Thank you very much.
Thank you for that. That was really a fantastic spectrum of responses that helped to capture the importance of how narrative matters, and what people hear in media is what tends to sink in. And in order to address inequities, we need to start with undoing those narratives. And the other thing that I heard from you all is the importance of infrastructure, whether it be the infrastructure of the United States itself and undoing racism, all the way through to the infrastructure of technology and access to technology that will allow the ongoing learning that's so critical in terms of not only addressing COVID pandemic, but really the pipeline issues that help us with representation in STEM. So let's turn to the third final question before we go to questions from the audience. Moving forward to the post-COVID rebuild, what do you think is the most important to address within your respective domains that will contribute to eliminating, we're now shifting to eliminating health inequities for Latinos? And let me start with Eduardo, please.
So I would say I've said a bunch of stuff, and I think the simple way of answering your question would be to walk the talk. So I am involved with many others at the American Heart Association to both internally and externally move the conversation about dismantling structural racism at best, and at worst, mitigating the effects of structural racism. Internally, we're committed to looking at ourselves, making sure that diversity and inclusion are not only words that we use, but we create the realistic opportunities for our workforce to thrive, and particularly that workforce that are people of color. We've also got 30,000 people who call themselves members of the American Heart Association. There's a fair amount of diversity there. We want to make sure that representativeness on our science councils, representativeness at the leadership of science councils begins to look like the United States, and we can get there. And then lastly, we are associated with 12 different journals, and we are committed and have put in place the steps to make sure that the science that says diversity equals better outcomes in so many realms. Eduardo talked about some of those before. We want to make sure that there is a perspective on diversity, inclusion, and equity through our journals and the peer review process that goes on. And then externally, we want to advocate for that diversity, equity, inclusion, and anti-racism, but also want through our advocacy to push for some important issues. Expanded Medicaid, so more people have insurance. Expanded federally qualified health centers, so that the uninsured, underinsured, and sometimes underrepresented and underserved still have a safe place to get care. I came up through the federally qualified health center system, and when Medicaid managed care happened in Texas, we were worried people would go away. They left for a little while, and they came back. They came back to a place where people cared about them, looked like them, and provided them user-based, patient-centered care. We are going to advocate for housing and improved housing and access to and improved quality of schools back to what Randy said, using science and evidence-based to make sure that what's being provided in the schools is high quality, but also making sure that there's equitable access to it. So both internally and externally, our organization is committed to doing this work. Last thing I'll say, the word allyship is in our paper. And in my mind, allyship is not only, I think it's both a vertical allyship and horizontal allyship. We want to work with any organizations that have a like mind to dismantle structural racism, all in the name of making ourselves allies with those who, for the moment, can't defend themselves, try to bring that community to a place of more power in this struggle to eliminate structural racism.
Fantastic. Thank you so much. I'm going to turn now to Randy.
And Eduardo, we want to be your allies in all of this. So thank you. So we would love to work with you on any and all of these kind of issues. So, it's an overwhelming question that you ask, Dr. Barbeau, in a moment when we don't know whether or not Joe Biden is going to be able to fulfill the promises made, given who may be in the Senate of the United States. But that's why I want to start where Dr. Sanchez ended, which is there's a lot of stuff that we can do, or that Joe Biden and Kamala Harris can do through executive action to actually take lots of different things that are already on the books, the CHIP program, the ACA, Medicaid expansion, and find ways of making sure that they start plugging in the holes that we have right now that we're seeing in a very tattered healthcare system. Would it be better if we could actually have a public health option that then becomes competitive with health insurance companies? Yes, of course. But the key is speed to create trust that the federal government can actually do the bidding of working families, as opposed to simply, the oligarchs who have done quite well during this period of time. So sorry for my politicization. So I do think that the kind of list that Dr. Sanchez just listed, if we can actually use community schools, use schooling as a way of creating ways for families to get health insurance, really important. Expanded Medicaid, really important. Figuring out a fair way of vaccinations, as well as the trust that ultimately the vaccinations will be, are ready and are fine. All of that's going to be important. And schooling has to be both higher ed campuses as well as pre-K-12 are going to have to be really important places for us to be able to do this. The second piece, though, is going to be at this how do we, and I keep saying this word trust, how are we going to create the trust that people come first? And so I think that the allyship becomes very important. I also think we have to make things work like OSHA so that workers feel like they are protected as well, and that ICE is not going to be knocking on every employer's door, or on and on and on. So that's why I come back to what are going to be the trusted emissaries for us to actually then take what is on the books, make it much better, work together so that in 6 months from now, 3 months from now, 6 months from now, people see they can get health insurance. They can make sure that a vaccine is free for them. They can make sure that a test for COVID is free, that ICE is not going to come knocking on their doors if they get medical treatment, that we do this in multiple languages. And as I keep saying over and over again, I think the schools are going to provide a very important way of creating that trust and creating that network.
Terrific. Thank you. Let me turn now to Eduardo Setlin.
I will add and say building trust and developing meaningful partnerships are absolutely critical. Completely agree with both Randy and my tocayo. And I think namesake is a word in English. In Portuguese, it's xará, but that's a completely different topic. I'd add the creative problem solving on top of it all. And I'll give you an example very much in the biotech industry when we talk about oncology clinical trials. You know, medicines don't become a reality unless we follow the complex FDA approved clinical trial pathways. It's critical to get those meds to patients. We know that 70% of Americans are willing to participate in clinical trials, but fewer than 1 in 20 cancer patients have participated in one. When you look at the representation of minority populations in clinical studies, in the oncology space, is even more disparate. African Americans are 12% of the population, 5% of clinical trials participants. Latinos, again, 16%, and 1% of the cancer clinical trial population. Now, we don't have the time for a conversation on all the whys, but every time we start this conversation, we turn to trust and Tuskegee comes up, which is sadly, but just one example of the many past practices. If you haven't checked out, there's a terrific book by Harriet Washington called Medical Apartheid that tells the history of medical practices in this country. But within this context, and in a business that has, dozens of molecules under development for the treatment of cancer, we were approached by an organization called Lazarex Cancer Foundation. And they said, listen, we have this pilot that shows that it's possible to improve patient access to cancer clinical trials. And we have 4 pathways to do that. 1, we provide financial support for the ancillary costs, the transportation, the lodging, what it takes to get to the trial, to the site where there is a trial. 2, long-term partnerships with these cancer centers so that the doctors are speaking the language of the patient and understanding their reality. 3, culturally sensitive community outreach. And then, of course, thoughtful dialogue with policymakers to create infrastructure to allow these conversations to happen. The pilot of this effort drove a 29% increase in patient enrollment in cancer clinical trials and doubled minority participation. A more recent grant we supported from 2019, 2 sites in California showed 65% racial ethnic minority participation in clinical trials and 57% of participants coming from households earning less than $25,000. Clinical trials means hope. Clinical trials means a possibility of extending quality of life. So again, a much narrower take than the big picture that my colleagues talked about, but I think a terrific illustration of what's possible in terms of developing partnerships and building trust to bring improved quality of life to all of us. Thank you.
Fantastic. Thank you very much. And then I will turn to David, who's batting cleanup on this round.
Okay, thank you. Well, actually, we see the recovery post-pandemic, and we see it in the Latino GDP. There was a V-shaped part of the recovery, and that was in Latino labor force participation. That is, it dropped down, yes, it did, in March and April, bounced right back up in May, has been going up ever since. And in many other, in household formation, likewise, there was a little drop, bounced back. Latinos actually can power this V-shaped recovery. However, as we saw, by the nature of the many jobs that Latinos fill, that exposes them more to coronavirus. So how long will that be able to be sustained? Nonetheless, we see another very strong piece of this recovery in Latino education. While I still hear people saying, well, half of Latinos drop out of high school, that is so like 1970. 90% of Latino students in the U.S. today graduate from high school, 70% go on to college. However, there's a big difference between the time when I went on into college, and I'm part of the baby boom generation, and when my children went to college. When I went to college, 1963, I wrote my first check to the Regents of the University of California, $108 a year, and I got the best education, bachelor's, master's, PhD. My children graduate. My son is carrying $90,000 of student debt. Well, Hey, we know what to do. Why did the baby boomers get educated for free, and now these post millennials are being saddled with so much debt? They also want to set up households. When the baby boomers and parents of baby boomers wanted to set up households and buy houses, we had Veterans Administration that helped them get into housing. Now housing prices are going out sky high, and the millennials are saddled with debt. We know what to do. We just need to give the multiracial, multicultural, post-millennial generation the same opportunities that we gave to the baby boomers, and Latinos will take it from there, and we will help push the recovery through this pandemic. Thank you.
Fantastic. Thank you so much. So what I would like to do now is turn to questions that we've gotten from the audience. I think for this first question from the audience, I will have each of you respond, and then for the subsequent ones, I may just ask one or two of you directly to answer the question. And so we'll do this for about the next 20 minutes or so. So let me start with the first question from the audience, which is, what are the top 3 most important issues for the Latino community that the Biden administration will need to address? And in this, why don't I begin with Randy? I don't think we're hearing Randy.
I was on mute. Education, healthcare, and jobs. I think that, long term, we're also going to have to make sure that, like what Joe Biden will do immediately is he's going to make sure that that everybody understands that DACA, that those who have DACA are going to be protected permanently. Those who are in TPS are going to be protected permanently. That's going to send a message that immigration is going to be fair-minded, but we're going to need the Senate and the House of Representatives to have a long-term pathway to citizenship in a real and meaningful way, where there's the appropriate, that all of the appropriate things are taken care of. But I think that what's important here is that, given the inequities of the of where we are right now, we have to make sure that we have good wages and good jobs and protection and employment for our essential workers, many of whom disproportionately are Latino. We have to make sure, and I think Dr. Settlin said this earlier as well, we have to make sure that every kid is entitled to a great education, regardless of where that school is. And we have to make sure that we deal with all of the issues around healthcare. And so the issues that Latino families have are the issues that Indigenous families have, are the issues that African American families have. And we got to make sure that this world, in a very intentionally looks at and has a very anti-racist policy. But what we know about America is this: that when we actually help families help themselves, America thrives. And the polarization that we have seen in the last few years, the fear of the other, if we focus on education, on jobs, and on healthcare, then that, I think, long term will help dissipate the fear of the other.
Terrific. Thank you very much. Eduardo Sanchez, please.
I'm going to go a little bit more high level, but I agree with every single thing that Randy said. I would say, in the name of anti-racism, we got to tone down the rhetoric. There's just a lot of hateful rhetoric out there and a lot of finger pointing. That's got to stop. I think that representativeness, on the one hand, is critically important. The folks who are at the tables that are going to be making the decisions and engaging in those policies need to look like and bring the perspectives of Latino Hispanics. When those diverse perspectives are brought to a table, more opportunities emerge. And in the same vein, we need to meet people where they're at and engage communities in trying to find the policy and programmatic solutions that are out there that maybe they can point us to. But too often we approach these things as folks who know and want to help. I was trained to do that as a physician, not good training. I then figured out that asking my patients what they wanted to work on, finding a way to build a relationship, and then maneuvering to better health was the way to go. So again, tone down the rhetoric, representativeness at the leadership level, and then engaging our communities to be the solution finders and the solution seekers and the implementers.
Terrific. Thank you very much. David.
Okay. I think at the very top level, the most important thing that we need to do to move around a lot of this current polarization is to create the Latino narrative about Latinos in the United States. It surprises people that for the 50 years that we have polling data around, if when you ask Latino potential voters, what are the most important issues for you? It's always been consistently education, number one. Income, number two. Not so much jobs. Latinos work. We just don't get paid, but we work like crazies. How about some income for the work? And the thirdly, healthcare. That has not budged in 50 years. And those are the same issues that bother all Americans. We are part of this great country. We have helped form it. And I have a quick suggestion how we can start to move around all of this. Let's make Cinco de Mayo a national holiday. Why? Not the Drinko de Mayo. Let's go back to the American Civil War origins of the Cinco de Mayo. And the Civil War was fought on the basic issues that we are fighting today: race, citizenship, governance, participation in the society, being able to enjoy the benefits. And remember, Latinos helped to bring about the Civil War because we refused to give on slavery. We wouldn't let slavery into California. We supported abolition of slavery. We supported racial equality. We supported women's rights. We supported language rights. Hey, that was 170 years ago. We need to bring back Cinco de Mayo to its origins as a celebration of human rights, of civil rights that helped to build this great country. And that is a good start to create our Latino narrative about Latinos in the United States. We gave it some of its best values. Thank you.
Thank you. And now Eduardo Sutton, please.
It's hard to add in terms of additional priorities. I love the summary of education, healthcare, and jobs. I would add, I think the opportunity now is one, and let me talk a little bit maybe about the how. And I'll three ideas. I think first is, how do we overcome the tyranny of or? So many conversations are framed as, is this A or B? There are situations where that's absolutely critical when you talk about systemic racism, absolutely. But when it comes about implementation of different ideas, the end sometimes can be very powerful. Two, a beginner's mindset. There's some research from the early 2000s that shows, they took a simple problem and asked kids 5 to 10 to solve it, and the 5-year-olds did it much better than the 10-year-olds. And essentially, they didn't have a constrained mindset, and they thought about possibilities that grown-ups at 10-year-old were already not thinking about. And if we're able to do those two things, I think the path forward is really one of inclusive innovation. I am an immigrant. I've been in the United States for 20 years. I've made a career here that would have been impossible in my home country, Brazil. This country is at the cutting edge of what's possible, of what to do with science, of what technology can afford us. Back to education. Is it in the classroom or is it virtual? Well, we heard from Randy and from Saukan. It's both. Let's rethink possibilities. Let's have different conversations, and let's find ways to do things together, the power of partnerships.
Terrific. Thank you. So the next question that came in from the audience, I'm going to broaden it a little bit. we've been talking about the role of technology in distance learning, remote learning for our school-age children, but we haven't really talked about the issue of technology in telemedicine. So I'm going to broaden that conversation a little bit for members of the panel to talk either about the degree to which remote learning is creating challenges in the Latino community, the degree to which telemedicine may or may not be readily adopted by Latino families, and then the degree to which the digital divide is either hindering or accelerating Latinos' ability to be a part of the way in which our country is so rapidly changing with regards to technology. So let me begin with Eduardo Sanchez on this one. And maybe if you could talk a little bit about what you've seen, what the American Heart Association may have seen with regards to telemedicine and Latinos. And this, I'm going to take moderator privilege on this one and just add a little bit that what we saw here, which is going to give you all a little bit of time to think on this response, what we saw here in New York City in terms of needing to rapidly move from in-person healthcare to telehealth was twofold. One is, one of the myths that we had in medicine, I think, was that people in the older age groups would be unlikely to adopt to this technology. And actually what we've seen is that the senior citizen population has been some of the earliest adopters to the use of telemedicine. And obviously out of necessity, this has been so. Additionally, we've seen people adopt telemedicine for mental health to a greater degree than we thought previously was going to be feasible. And then the other thing that I will sort of note on the other side of telemedicine is that part of the challenges for primary care practices that Latino physicians may be running or that they may be a part of is that some of these practices may not necessarily have the technology infrastructure to fully leverage and incorporate telemedicine into their practices, or they may be part of practices that haven't yet fully leveraged the billing system to ensure that they are able to continue moving forward with telemedicine. So I think that that's an area where both from the Latino patient perspective as well as from the Latino provider perspective, I think more attention needs to be made to ensure that that infrastructure is as robust as we need it to be, both for this COVID resurgence as well as for the post-COVID rebuild. So Eduardo, let me turn it to you to talk a little bit more about maybe the telemedicine or other aspects of the digital divide.
We could do an entire 2 to 3 hours on this particular topic, so I will try to be brief. I do think that one thing can be said. COVID-19 forced us to do the experiment, and I think from a proof of concept perspective, telemedicine works. That doesn't mean that there aren't nuances. That doesn't mean that there aren't some challenges. That doesn't mean, but the idea, can we do this? I think we've demonstrated it can be done. I think to the points that you're making, Dr. Barbeau, there's the issue of does the full universe of providers have not only the capacity for the technology, but know how to use it well? Because one of the questions that I have has to do with who's on those calls. When you who's on that telemedicine call. When you go to the doctor's office, the drill is the same for every single person participating here. You show up, you go to a waiting room, you get registered, you get checked in, you wait in the waiting room. Somebody comes and gets you. They do some stuff with you. They walk you into a room. They talk to you while they're doing that, getting some information. You then have a visit with the doctor or whoever the clinical provider is. And then on the other side of that, there's another conversation that goes on, and then you get discharged. there's a whole lot there. That's called team-based care when it's done really, really well. And I think that one of the hows is how do we do team-based care using telemedicine? We know we can use the platforms. I'm not sure that we figured out the best way to do that kind of work. I think back to what Eduardo said before about dualities. We have these false dualities of all one thing or all another. I do think that the future is going to be a hybrid. It's going to be a mix of in-person visits and remote visits. There are times when it's really, really important that the clinician and the patient are in the same space having a conversation, just like so many other things that are true about our lives. But there are other times where right now, the inconvenience of going somewhere, we now know we can do a blood pressure check remotely if our patient has the right devices. And I also think that it's important for us to engage users. My wife is now the chairperson of a board of a federally qualified health center, which have great models of 50+% user boards. Let's use users, patients, to help tell us what are the things that will make it easier to get this done and not done. And again, that was 2 minutes, just rapid fire stuff. But I believe the future is bright. Getting broadband access is a matter of political will, not a matter of it can't be done. The platforms exist, and using the kind of rigor that we apply to so many things that we do around basic science and clinical science and now implementation science, I think we can perfect the delivery of medical care in a hybrid way using technology in a smarter way than we're using it that complements the in-person kinds of clinical care that sometimes absolutely has to happen that way.
Terrific, thank you. I'm going to then turn to...
Yeah, can I jump in just
turn
for...
to... Yeah.
Because I think that part of... There's the promise of something, and then there's also the reality on the ground. And even before COVID, Latino households were 37% less likely to have reliable internet access. And I think that this same issue goes for internet access for schooling as internet access for telehealth. So let's assume for a second that telehealth, just like remote education, has its place. I don't know about everyone else on the panel, but I have spent most of the last 8 months knocking my head against the wall, trying to beg the internet companies to find different ways of extending reliable internet. And I'm not just talking about rural areas. I'm talking about, in areas like a New York City or an LA or where, because for most of us, and I suspect most of us who are listening, have reliable internet. Mine at home costs $250 a month. That's not something that every family is going to be able to do. When we are on this, we have to be on high-speed internet, doing all this kind of work. It's out of the realm of possibility. This is the kind of thing that we need to make sure for telehealth to work, that everyone has access to high-speed internet in the way we have access to radio waves, in the way we have access to electricity. This has become key to survival right now for, I'm not talking about the machines, I'm just talking about reliable connectivity. And it has to be just like the Tennessee Valley Authority, just like the kind of electricity work that was fixated on in FDR's time. This has to be a fixation of a national dimension, just like radio and electricity was. If not, then we end up having the same conversation about equity on telehealth or on remote education.
Completely agree with you, Randy.
Thank you.
So wasn't meaning to pass over that at all, and would say an equity frame and an equity purpose has to be part of that discussion. And just one last thing is That's the sort of thing that we need help from a policy perspective and from a public-private perspective to push forward as an imperative. And I couldn't agree with you more.
I'm going to have
just
Eduardo.
going, yeah, just it's if you look at the challenge from what can be done by different groups and different set of stakeholders, yes, I think the cable, the internet companies have a lot of work to do, but we need leadership at the national level and policy driving investments that are massive and that hopefully will create fantastic jobs while we're doing that, and looking like parts of China where it doesn't matter where you are, everyone has access to the internet. And what I find is also critical is this moment in telehealth, this the way Dr. Sanchez framed the reality today of, yes, we're forced into this experiment and we know more than we did 9 months ago about what's possible. So I think there's a huge opportunity to test and pilot that model. I mean, the idea of, depending on the disease you have, you spend a whole day, the productivity, you need a day off to go to the hospital and fill out the same form for the 15th time. The system has flaws, and again, because it works, but it has flaws. How do we reinvent this moment and both at the national level have leadership, create jobs, get everyone internet, and in a lot of ways create a different avenue for care to be provided? And last thing I would say is, talk about the telephone companies. The developing world never laid out the foundation for the phone line that we have at home with cables. They leapfrogged it straight into cell phones. Can we do something like that?
Terrific. Thank you. David.
Well, let me kind of put my arms around all of this. I think it's important for us to understand how much the narratives that people have in their heads drive policy decisions. And the current narrative about Latinos in the U.S. is not a very positive one. We're always criminals, foreigners, immigrants. We speak the wrong language. So what we need to do, among other things, is help create the Latino narrative about Latinos in the U.S. The Latino GDP can power us, the GDP, through the post-pandemic recovery, but we do need to keep the Latinos who are working healthy. We need to keep the Latino businesses that are being established safe, and we need to invest in the education of the young Latinitos. We need to create this narrative, and we have it right in front of us. Again, the Cinco de Mayo. It tells people we're part of the U.S. And when this country was at the Great Divide 160 years ago in the American Civil War, Latinos came down on the side of freedom, equality, and democracy. So let's share that story. Let's create our own narrative, and that's part of the American narrative. This is why Latinos are part of the United States.
Thank you. So we're going to transition now into the closing statements, and I'm going to ask the members to keep their statements to less than 90 seconds, please. And let me begin with David. We're going to go the opposite way now. So David, please.
I can do it very quickly. Remember, narratives drive policy. We lack our own narrative. I was never taught one in school, but we have been part of the United States since 1521, for Pete's sake. We just need to let people know that and share that so people can understand, in fact, as we move the Latino GDP ahead, that benefits everyone. Thank you.
Thank you. Randy.
Sorry, I always put myself on mute. When President Obama was running, one of the things that he said in virtually every rally was "Si se puede." And regardless of whether you were a Spanish speaker or not, everyone understood that was yes, we can. And it was done in a way of saying that we are better than right now if we are together, if we are we the people. I think David is absolutely right, that we have to find ways that we lift up the aspiration of all. I come from a family that escaped Ukraine and Russia, and whereas we found discrimination in this country, opportunity, and what we all need to do together We will soon become a country where our Latino population is the dominant population. And we need to make sure that we make things better for all, and we things that we all believe in: jobs for all, healthcare, education. Ultimately, I think that will make the country better, create a dynamism that is going to be helpful to take on racism and to take fear. So I'm all in with you, David, in terms of creating new narratives. Thank you.
Thank you. Eduardo Setlin, please.
Thank you. I just maybe close in a slightly different point. If we were in a real, in a pre-COVID world of a conference room, would probably be every one of you would have been meeting old friends, making new ones. You'd start conversations with the people around you. Hopefully, some of you would be lining up to talk to us afterwards, and we would continue conversation. The folks at CHCI would have been creating, coffee breaks, ensuring primarily after lunch.
I think we're having issues with Eduardo's feed. So why don't I transition to Eduardo Sanchez, please?
I'll try to be quick. I would say sí se puede. Sí se puede, pero necesitamos ser invitados y participar. We have to be invited and participate. And I will sort of flip what David is saying. I do think we need to own our narrative. I do think we need to not just ask, we need to demand that we be at the tables, at the decision-making tables. I'm going to say three things. Trust is really important. The three things that go under that: messenger matters, message matters, motive matters. And we need to be at the table as a messenger with the message, with our understanding of motive, to change the trajectory to a better trajectory for Latino health.
Thank you. Thank you, Eduardo. And Eduardo Setlin, I see that you're back with us. 30 seconds, please.
Just thank you. Get to know each other. Participants, look at the list of who's engaged.
We seem to have trouble once again. So why don't I then transition us to thanking the panel for a very lively and engaging, wide-ranging conversation on Latino health, the state of Latino health, the degree to which racism, structural racism influence those health outcomes, and a path forward. And, part of what I'm taking away from this conversation that I hope our audience takes away is the degree to which narrative matters and the degree to which we as a Latino community can own our narrative and reframe the health needs of our community, not just about healthcare access, but what creates health more broadly, including educational opportunities, economic opportunities, and as Eduardo Setlin quoted from Hamilton, I will also quote from Hamilton the importance of being in the room where those decisions happen and the importance of having a pipeline that contributes to that ability. So thank you all for spending part of your day with us. I hope that you learn some new things, and we look forward to the next opportunity. So thank you all very much.